In this screencast, I would like to talk to you about the mechanics and the physics of breathing, including pressure relationships, explain the role of pulmonary compliance and elastance, and the role of autonomic nervous system in the regulation of airways resistance. Breathing is a two-step process where air enters and exits the lungs and involve pressure differences. Inspiration is the first step, is an active process where lung volume increases and lung pressures decrease according to the Boyle's law. We will talk about it in a second. On the other end, expiration, the second step, is a passive process. Lung volume decreases and lung pressure increases. Inspiration involves the contraction of the diaphragm and also external intercostal muscles. Can involve additional muscles if a bigger breath is required. What happens during inspiration? The diaphragm contracts. It moves inferiorly toward the abdominal cavity. By doing so, it's creating a larger thoracic cavity and more space for the lungs. Contraction of the external intercostal muscles will move the ribs upward and also outward. By doing so, the rib cage will expand and will increase the volume of the thoracic cavity. Because of adhesive forces of the pleural fluid, the expansion of the thoracic cavity will force the lung to stretch and expand as well. This will result in an increase in the intrathoracic volume. Because of that, there will be a decrease in the intrathoracic pressure. And this is regulated by the pressure-volume law, also known as Boyle's law, which says that the volume of a given amount of gas at a constant temperature changes inversely with the applied pressure when the temperature and mass are constant. What does it mean? It means that as volume increases, the pressure will decrease. On the contrary, as volume decreases, the pressure will increase. So what happens in the lungs? I mentioned that during inspiration, there is an increase in the intrathoracic volume. This will lead to a decrease in the intrathoracic pressure because of the Boyle's law. And this will create within the lungs a pressure which is lower than the atmospheric pressure. So there will be the creation of a pressure gradient, a difference in pressure between atmospheric pressure and intrathoracic pressure, and this will drive the pulmonary ventilation so that the air can flow into the lungs. During expiration, which is a passive process, when diaphragm will relax and also the external intercostal muscle will relax, you will have a decrease in the thoracic cavity volume and therefore in the lungs volume. Of course, you will have an increase in the pulmonary pressure and the air will be driven out by a reverse pressure gradient. I mentioned it's a passive process. However, abdominal muscles and internal intercostal muscles can be occasionally involved in the process. So we learned that pulmonary ventilation depends on different pressures, and you need to learn the pressure relationships in order to fully appreciate the pulmonary ventilation. So obviously the pulmonary ventilation depends on atmospheric pressure, depends on intraalveolar pressure, sometimes referred as intrapulmonary pressure. when the pressure inside this is the pressure inside the lungs, which will decrease as lung volume increases during inspiration, as we mentioned earlier, but will increase during expiration. Another important pressure I like you to remember is the intrapleural pressure. This is a pressure within the pleural cavity. This is more negative as the chest expands, but it returns to an initial volume or initial pressure as chest recoils. What is this intrapleural pressure? It is a pressure created by two opposing elastic forces. One force pulling inward due to the tendency of lungs to collapse, and one force pulling outward due to the tendency of the chest wall to spring out. This will create the intrapleural pressure. And in this cartoon here is represented is a representation of how the intrapleural pressure, the transpulmonary pressure, will change during the inspiration and expiration process compared to the atmospheric pressure. As you can see, the intrapulmonary pressure in relation to atmospheric pressure at the start of the inspiration will be equal 0. The intraalveolar pressure will be 760 millimeter of mercury, so it's going to be equal to the atmospheric pressure, so the difference will be 0. And the intrapleural pressure will be -4. Both pressure will decrease during the inspiration, but will return to more positive values during expiration. And then on the figure on this graph here, you can see the volume expressed in liter of the amount of air in our lungs during the process of breathing. During the inspiration, you will have an increase of volume inside the lungs that will decrease during expiration. Transpulmonary pressure is another pressure that I would like you to mention, which is due to a difference in pressure between intrapulmonary or intraalveolar pressure and intrapleural pressure. What happened if the intrapleural pressure, which I mentioned is tend to be negative, becomes equal to the atmospheric pressure? Well, the lungs will collapse. This is a condition called pneumothorax, and you might hear about it when practicing in the hospital or as a healthcare professional. And it's due to the presence of air or gas in the pleural cavity. Why? Well, because of a trauma, because of an injury, the intrapleural pressure may become equal to the atmospheric pressure. And this scheme in here is just for you to notice that the pneumothorax can be spontaneous due to diseases or can be traumatic as a consequence of a stab, for example, a stab wound or a gunshot injury. Can be non-iatrogenic, as I said, because of an accidental trauma, or iatrogenic, due, for example, to an interventional procedure such as lung biopsy or tracheostomy. You don't have to remember all the details, but so you know that pneumothorax can be of different origins. And this slide, I would like to bring together all the information I provided you about the process or the steps of breathing, the pressure relationship, and the volume of air you can find in the lungs during the breathing cycle. So in the relaxed state, so between cycle, inspiration and expiration, the muscles will be at an equilibrium. So the diaphragm is going to be relaxed at the equilibrium. The alveolar pressure will be equal to the atmospheric pressure, and air will not flow in and out of the lungs. And the volume of air in the lung will be equal to the functional residual capacity. Think about, you learned about the capacity in the previous screencast. The functional residual capacity is the volume of air that remain in your lung after a normal tidal volume, and is equal the expiration reserve volume and the residual volume. What happened during inspiration, during the active process of inhaling air into the lungs? The muscle will contract, the diaphragm will contract, the lung volume will increase, the pressure in the lung will decrease. Remember, Boyle's law. Because of that, the alveolar pressure will become more negative. There will be the flow of air into the lungs, and the volume in the lung will be equal the functional residual capacity plus 1 tidal volume. What happened during expiration or exhalation, which is a passive process? Diaphragm will relax, thoracic cavity and lung volume will decrease. You will have an increase in the pressure within the alveolar space, so the pressure there becomes more positive and the air can flow out the lung compressed by the elastic forces of the lungs. What happened to the volume in the lung? The volume will return to the functional residual capacity as you exhale the tidal volume. In the next couple of slides, I would like to talk to you about compliance and elastance. So to start with, to help you to understand these two concepts of compliance and elastance, I put in here two pictures of an elastic, a thin one and a thick one. Compliance is the measure of the distensibility of a system, and it specifies the ease or how easy it is to stretch a matter and distort it and change the shape. Elastance, on the contrary, is the measure of the ability of a system to oppose a stretch or a distortion, and to return to the original form or to recoil. So I think it's easier to understand this concept if you think about a thin elastic, which is easy to distend and modify, and to a thick elastic, which is opposing to a stretch that you would like to apply to it, and it tends to return to the original form. Why I like you to understand these two concepts? Because understanding compliance and elastance is a key to understand the lung mechanics, and because the compliance and the elastance of the lung determine how much the lungs can inflate or deflate, and by doing so, how the pleural pressure or the pressure within the lungs will change. And the problem is that compliance and elastance are changing during diseases. So going back to the definition of this concept in the lungs, lung compliance is the volume change that could be achieved in the lungs per unit pressure change. Basically, it describes the ability of the lung to expand under pressure. On the other end, elastance is a reciprocal of compliance, and is the pressure required to inflate the lungs. So it's the pressure change that is required to elicit a unit volume change in the lung. Basically measure the work that has to be applied by the muscles during inspiration to expand the lungs. And elastance and compliance can change due to physiological and pathophysiological conditions. And obviously, a change in compliance and elastance can lead to diseases. So, for example, if you have an increase in compliance, and this is something that you have during emphysema, next year you will learn about COPD. And emphysema is a component or is a pathological situation occurring during COPD. You have an increase in compliance. What does it mean? It means that it's easier for the lungs to expand, but by doing so, the chest wall can expand, but the recoil doesn't occur. So, meaning that during emphysema, for example, the FRC is increased because the lungs are more compliant, can inflate more easily. But then the equilibrium between the inward recoil of the lung and outward recoil of the chest is disturbed, and you will have a amount of air volume left in the lungs. This increasing compliance will interfere with the ability of a person suffering from emphysema to exhale, to get rid of the air within the lungs. On the other end, if you have a reduction in compliance, so you have an increase in elastance, it's going to be more difficult for the lungs to expand, and therefore, again, you will have a disturbance in the equilibrium between the inward recoil of the lung and outward recoil of the lung. So the chest can expand, is more difficult for the chest to expand, and it's going to be more difficult for a person to breathe in air. How airflow pressure and resistance of the lung relate to each other? Well, the law stated in here regulates these three different parameters. So the airflow is proportional, directly proportional to the pressure gradient, so the driving force for the air to flow in. However, the airflow is inversely proportional to the resistance, or to the airway's resistance, which is determined by this Poiseuille's law, which you don't have to remember actually, but is here for you to understand more how resistance, viscosity of the inspired gas, length of the airways, and radius of the airways can impact on the airflow. And as you can understand, obviously, the resistance is affected by changes in the airway's diameter. And if the airway's diameter will decrease, you will have an increase of airway's resistance, which will impact on the airflow. And it will impact in a way that the airflow will decrease as the resistance will increase. In the last slide, I would like to talk to you about the autonomic nervous system and how it can control airways resistance. So you will have the parasympathetic stimulation, which will mediate constriction of the bronchial smooth muscles via the muscarinic receptor. Acetylcholine will activate the muscarinic receptor, leading to bronchoconstriction and decreasing the airflow. You will have the we can block this system. You will learn in next year when we will study or we'll discuss the therapeutics used in treating pulmonary diseases such as asthma and COPD. You can block this muscarinic receptor using atropine or tiotropium bromide, and by doing so, you can obviously decrease the bronchoconstriction, thereby increase the airflow. You have the sympathetic stimulation, which will produce an increase, a relaxation of the bronchial muscles via activation of the beta-2 adrenoceptor. This bronchodilation will lead to an increase of airflow. Adrenaline will activate the receptor to increase bronchodilation, and salbutamol, as you will learn next year, is an agonist of beta-2 receptor, beta-2 adrenoreceptor, can be used as in therapy to promote bronchodilation during diseases such as asthma or COPD, to favor the bronchodilation and therefore to increase the airflow.